Good evening, everyone. And thanks for joining us. I'm trying to go back on the slides here. This is our 5th webinar. And today we have Dr. Hernandez to teach us about atrial fibrillation and the risk of stroke and our strategies to prevent it. But before we go ahead with today's webinar, I would like to review the past 4 webinars as we used to do for the next few minutes. And I would like to remind everyone of our mission is to make our community the most educated about atrial fibrillation in the nation. Very humble goal. During our first webinar in December, we had an overview of atrial fibrillation, and I introduced the members of our team as a multidisciplinary team taking care of all aspects of atrial fibrillation. And Dr. Hernandez, you can see her in the middle here. And we discussed that atrial fibrillation is an electrical issue in the top chambers of the heart, results in loss of mechanical function that's appropriate mechanical function with hemodynamic consequences. And the most significant consequences, one of them is the formation of clots in the top chamber of the heart. And as a result, that clot can break off and go in the bloodstream to the brain and cause a stroke. And the main topic of discussion today is the risk of stroke in patients with atrial fibrillation and what can we do about it. We discussed pharmacologic and non-pharmacologic options. And again, we discussed that briefly. Today, it will be in more details. In our webinar 2, we discussed antiarrhythmics, which are the medications we use to help keep the rhythm and keep atrial fibrillation away. And we discussed the difference between paroxysmal atrial fibrillation, where atrial fibrillation episodes come and go on their own without need for intervention. Then persistent atrial fibrillation, where atrial fibrillation episodes has to be terminated, basically either by cardioversion or by medical therapy. And then permanent atrial fibrillation, when the decision is made by the patient and the physician after failure or efforts to maintain sinus rhythm to just live with atrial fibrillation. We discussed cardioversion, and we discussed the difference between transthoracic echocardiogram and transesophageal echocardiogram. And we also emphasized that class 1 antiarrhythmic medications are usually used in patients with healthy hearts. If you have atrial fibrillation and sick heart, meaning weak heart or prior heart attack, then other medications could be used. We call it class 3 antiarrhythmics. Again, for further details, you just go back to that webinar. And we highlighted at the end of that webinar that atrial fibrillation ablation procedure is consistently more effective than medications in maintenance of sinus rhythm. Then we discussed at length in webinar 3, catheter ablation, how it is minimally invasive using a small catheter that's deflectable and maneuvered by hands, and how the point of contact between the catheter tip and inside of the heart through the flow of current we call radio frequency cause heat and damage to the tissue and create scar, basically disabling the areas of abnormal activity or create a scar, breaking down electrical circuits and restoring sinus rhythm. And we discussed the anatomy of the heart with the 2 top chambers, especially the one on the left, and how the opening of the pulmonary veins, which are the vessels that bring the blood from the lungs to the left top chamber of the heart, are usually the source of most of the triggers for atrial fibrillation. And that's why we target these areas with our ablation. And we discussed the lesions by creating circles of scars around those pulmonary veins and additional lines or additional spots, depending how many areas we need to target in order to restore sinus rhythm. But no matter how extensive the ablation is, we always go and create circle of scar around the pulmonary veins on both sides, making the signal basically disappear from inside the pulmonary veins. areas of purple, usually electrical activity, red, no electrical activity. So we electrically isolate those pulmonary veins, and that has been effective in most cases in maintaining sinus rhythm. More lesions, of course, could be needed. And we emphasized on the need to early diagnose and early intervene in case of atrial fibrillation in order to be with higher chance of successful maintenance of sinus rhythm. And we highlighted the two main modalities in catheter ablation, whether using freezing, what we call a cryoballoon ablation, or heat using radiofrequency catheter ablation. And we showed that different studies that consistently proved that atrial fibrillation ablation is a better way than medications maintaining sinus rhythm over time, and has been proven to be a good alternative and a safer alternative to medications. In webinar 4, Dr. Verma discussed in details the complications, safety, and our records regarding atrial fibrillation ablation. And today's webinar will focus in details on the risk of stroke and stroke prevention strategies, and will be presented by Dr. Hernandez, who is board certified in internal medicine, cardiovascular disease, and cardiac clinical electrophysiology. She joined us in 2019 after finishing her clinical cardiac electrophysiology fellowship at the University of Rochester, New York. Dr. Hernandez has been very dedicated to teaching our patients, our community, just like today, and healthcare professionals. And we really appreciate her being here today, and we're all here to learn from her. So without further ado, Dr. Hernandez.
Well, good evening, everybody. Thank you for having found time to join me for continued discussion about atrial fibrillation. It is actually fascinating that a single entity like atrial fibrillation can provide topics for a discussion on our webinar throughout the entire year and maybe even longer. It's just because this topic is so large. The issues related to atrial fibrillations are complex, and atrial fibrillation is just so common. So it does relate to a lot of people and patients. Actually, Dr. Alshik did me a favor. I thought it was my job to do the overview, but I will skip some of this part that he already covered. And we will go straight to the direct topic of my discussion today, which is atrial fibrillation and associated risk of stroke. And that's a unique characteristic of atrial fibrillation, that a lot of other heart rhythm issues are not associated with stroke risk, so we don't have to worry about this. But the stroke and atrial fibrillation is a very serious issue. It needs to be patient needs to be screened for the risk of stroke, and appropriate strategies needs to be instituted to protect our patients from occurrence of stroke. In general, atrial fibrillation increases risk of stroke 5-fold. And the truth is the risk of stroke increases with age, as does atrial fibrillation, because the most serious risk factor for atrial fibrillation is actually getting older. And the other important fact is that atrial fibrillation-related strokes are likely to leave patients more disabled and actually make patients more likely to die. So that's why we as a physicians have pretty low thresholds to offer strategies to minimize risk of strokes in our patients. How much atrial fibrillation can cause a stroke? Because atrial fibrillation is a tricky arrhythmia, so it's not necessarily needs to be present all the time. Sometimes it comes and goes. Sometimes it comes for a few minutes, sometimes it comes for a few hours, few days. In some patients, it does stay and goes on for as long as it can. Some of our patients have pacemakers or defibrillators, and we as physicians keep an eye on the information we receive from those devices. And it's not that uncommon when device records atrial fibrillation that was not seen in particular patient before. So the question is, how much atrial fibrillation is enough to cause a stroke, and what would be our threshold to recommend protection from a stroke, primarily blood thinners or any other procedures? And again, there's no good consensus on that. If we look at the literature, some studies demonstrate that a single episode of atrial fibrillation lasting more than 6 minutes could be enough to result in a stroke. Other studies mentioned time frame anywhere from 5 minutes to 24 hours. So there's no good answer to this question. And a lot of times it's physician's judgment, how much atrial fibrillation patient has, what's the burden of it, and what is the patient's risk of stroke. And that's how decisions are made whether or not stroke prevention strategies are recommended. Mechanism of stroke and atrial fibrillation. Why is atrial fibrillation so unique in this regard? Because if we look at the left side of the screen, the first picture of the heart demonstrates electrical flow in a normal rhythm. In normal heartbeat is driven by the spot on the top right chamber of the heart called sinus node. And this spot generates electrical current, which then spreads to the rest of the heart and makes the heart pump. And the flow is nice and even. So usually there is no disturbances. It's sort of like a nice railroad track where train just goes forward down the railroad tracks. In atrial fibrillation, as you can see on the next picture of the heart, electrical flow on the top of the heart becomes very disorganized. And it's like a river with a lot of rapids. As a result, the top of the heart is not really pumping very well because there is no good, even electrical flow. And as a result, it creates, in a way, stagnation of blood, in particular in the dead end spots of the heart where clots can happen because of this stagnation and clotting cells getting stuck together. And in the middle black and white picture, this is actually a picture of ultrasound of the heart. And on the right side of this picture, you can see this structure outlined by a yellow arrow, which is actually a clot inside the dead end pouch in the heart called left atrial appendage. This is the most common spot where the clots get formed in atrial fibrillation. And left side location is important because from the left side, there is a straight shot to the brain through the carotid artery if those clots take off. And that's kind of my next picture would demonstrate that the heart has direct connection to the brain through the arteries. One of the classifications of atrial fibrillation that we follow includes dividing atrial fibrillation into valvular and non-valvular. So because knowing the type of atrial fibrillation really determines what kind of blood thinners patient can or cannot be a candidate for. Valvular atrial fibrillation is called when patient has an artificial heart valve made of metal, or if patient have a narrow valve on their left side of the heart, mitral valve, and the condition is called moderate to severe mitral stenosis. So with these conditions, if atrial fibrillation happens, the only blood thinners that we have to offer are warfarin or Coumadin and heparin or enoxaparin, which are injectable versions of it. And if we talk about non-valvular atrial fibrillation, which means all patients without those conditions, the risk of stroke will be associated with certain risk scale, of which we will talk about, and patient will have more options of the blood thinners to be protected from stroke. When we meet the patient with atrial fibrillation for the first time, we need to assess their risk of stroke because risk of stroke is really different for every patient. If you have valvular atrial fibrillation, as I mentioned, it's a metal heart valve or moderate to severe mitral stenosis. This is enough to classify patient as a high risk for stroke, and they have to be on blood thinners. However, if they don't have any of those conditions, how do we decide? There are different risk stratifying scales available for us. The most commonly used one is called CHATS2-VASC, and this is an abbreviation, and you can see how it's broken down. So C stands for congestive heart failure, or it's a condition when your heart strength is decreased or you have a weak heart. Generally, we look at the heart strength in the percentage form, and percentage form relates to the strength of the left lower chamber of the heart. So you get the point if your heart strength is less than 40%. However, even if your heart strength is more than that, but you had a flare of heart failure over the last year, you may still get a point in this category. Well, H stands for high blood pressure or hypertension, and that will give another point. A stands for age, and why there is a 2 after age, because age over 75 gives a patient 2 points. As we mentioned earlier, age is a very strong risk factor for atrial fibrillation and for the stroke. D stands for diabetes and gives a patient a single point. If patient already had a history of stroke, mini stroke called TIAs, or any other clotting disorders, it gives a patient another 2 points. If patient has peripheral vascular disease, which typically pertains to arterial disease, including coronary artery disease, prior history of heart attack, it gives somebody a point. Age 65 to 74 years adds 1 point, and being a woman gives a point. So on this scale, you can see how each number of scores correlates with the risk of stroke. If a man has a score of 0 or a woman has a score of 1, this group is considered to be a low risk and stroke protection strategies are not recommended, meaning that there is no data to say that patient needs to be protected. If a man has a score of 2 and a woman has a score of 3, this group falls at least to moderate high risk of stroke category, and protection from stroke needs to be instituted, whether it's a blood thinner or procedures. There is also a gray zone. So if a man has a score of 1 or a woman has a score of 2, so there is no strong data to say patients have to be on blood thinners or undergo procedures to be protected from stroke, but the guidelines would say that blood thinners can be considered in this group, which a lot of times depends on the patient's preference in this circumstances. Well, the patient's protection from stroke, which is usually consists of blood thinners as a first line, has to be balanced against patients' risk of bleeding, because what do blood thinners do? They thin the blood. They don't treat atrial fibrillation as a rhythm. They just thin the blood and make clots in the heart less likely to appear and cause a stroke. But naturally, if you have thinned blood, you're more likely to bleed, especially if you already have a reason to bleed. And there is also a risk classification available, more than one, that could help to risk stratify patients in terms of the bleeding and decide which strategy of stroke prevention will be the best. The most commonly used in my practice is called HAS-BLAD score. Again, this is an abbreviation where H stands for high blood pressure, A stands for abnormal kidney or liver function, S stands for history of stroke, B stands for bleeding, if patient already had any significant bleeding issues. L stands for labile INRs, and this is a blood marker that is monitored for patients who are taking Coumadin. E stands for elderly, meaning patients over 65 years of age, and D stands for drugs or alcohol. And you can see on the right side of my table what each number of points, how each number of points correlates with a bleeding risk. Generally, if you have 0 to 2, your risk of bleeding rather low, but if you have 3 or higher, your risk of bleeding is high. And there is a recommendation to consider strategies to protect patients from stroke, which are different from blood thinners. A risk of stroke varies throughout patients' care episodes, and it's important to recognize that after certain procedures, the risk of stroke will go even higher. And that would mean that if somebody has a low stroke risk and is not recommended to be on a blood thinner long term, after the procedures of certain kind, they will be asked to go on a blood thinner temporarily. Let's say if a patient undergoes a procedure called cardioversion, of which Dr. Alshik spoke. After that procedure, the risk of stroke goes higher for about 1 month, and patient will need to be on a blood thinner for that duration. If patient undergoes ablation for atrial fibrillation, even if they were not on a blood thinner previously, we would put them on a blood thinner for at least 3 months, because again, when we cauterize the tissue in the heart, the risk of stroke increases. So we want to make sure our patients are protected during this 3 months of healing period. And after that, the risk of stroke goes back to baseline. When we think about protecting patients from stroke, plan A is generally anticoagulants or blood thinners. And there are different kinds of them. First one is called warfarin or Coumadin. And this is the oldest blood thinner, and it has been around for more than 50 years. And but the interesting fact about it, that back in time, it was originally used as a rat poison. And eventually it was obviously modified and adjusted for safety for human use as a blood thinner. This is a tricky one because it does come with a need for regular dose adjustments because it does interact with multiple medications. It comes with a certain dietary restrictions, such as green vegetables will need to be limited among others. And the dose will need to be adjusted based on the regular blood work, which will need to be done sometimes once a week, sometimes once a month, because we need to keep that parameter called INR within the range 2 to 3. And those of you who are on Coumadin, that would be probably quite familiar with this protocol. For those reasons, if patients have other options in the modern times, it's usually not patient's favorite, but again, it's the only pill option for patients who have valvular atrial fibrillation. And to my knowledge, this still remains the most affordable blood thinner on the market. The newer blood thinners came out just over the last few years, and they do offer an advantage of being a pill. Some of them are taken once a day, some of them are taken twice a day. They generally do not require any regular blood work monitoring or dose adjustments. They do require assessment of kidney function at least once a year, because for 3 of them, like dabigatran, apixaban, rivaroxaban, the dose will need to be adjusted. And this adjustment really depends to a great degree on renal function. So we have to check the kidney function baseline, and then keep an eye on it while patients remain on the blood thinners to make sure the patients are on appropriate doses of those medications. It's very important that fact for rivaroxaban, also known as Xarelto, this medication really needs to be taken with food. And this is really a big deal because if medication is taken on an empty stomach with no food around, patient can really lose up to 40% of the medication effect. That would mean that they will only get 60% of the medicine working for them. But again, essentially they may be left underprotected from stroke. So food was, as a result, is very important factor. And typical recommendation is for this medicine to be taken with the biggest meal of the day. So a cup of coffee and a cracker, unfortunately, do not count as a meal. It has to be the biggest meal of the day, which is dinner for most of the patients. Another question I hear about apixaban, which is known as Eliquis. You can see there are 2 doses for atrial fibrillation. There could be different doses if we treat other clotting disorders. With apixaban, we offer 2.5 twice a day or 5 milligrams twice a day dosing. And those adjustments will depend on the age, renal function, and weight. Typically, according to the manufacturer's guidelines, the dose of 2.5, which is reduced dose, will be recommended for the patients who have 2 out of 3, age over 80 years, if body weight is less than 60 kilograms, or if the blood work parameter for kidney function called creatinine is more than 1.5. So if you meet 2 out of 3, you would be a candidate for reduced dose of apixaban. And you cannot cut apixaban. So if and probably most of these blood thinners, because they're designed to be taken as a whole pill. What happens if you're on blood thinners and you need other procedures to be done or other surgeries to undergo? As you know, probably surgeons do not like to do those procedures when patients are on blood thinners because generally the risks of bleeding will be higher. As heart rhythm doctors work, we receive a lot of requests from surgical offices asking for advice on what to do with blood thinners. And for most of the patients, the blood thinners will be held for a few days prior to the surgery to allow for the surgery or procedure to happen, but they will need to be restarted as soon as possible. From surgical perspective to restore that protection from stroke. What if the patient is at very high risk of stroke? Or what if the patient already had a stroke when blood thinner was held in the past? Or what if the patient had a recent stroke and they still need a surgery? So that becomes a little bit more challenging. So typically the blood thinners that are taken in the form of a pill, they last longer. So that's why surgeons prefer to hold it for a few days. But for those patients, we may have to start injectable blood thinners like heparin or enoxaparin to bridge this period when pill blood thinners will need to be on hold to allow surgery happen and then restart the usual blood thinner, because just risk of stroke is so high and we cannot take the risk of patient having a stroke. The same thing happens if patient underwent a procedure, let's say cardioversion, which we spoke about, or ablation, and patients need the procedure within 3 months after the ablation or within a month after cardioversion. Again, blood thinners in the form of a pill can be held, but injectable blood thinners may need to be instituted until pill blood thinner can be restarted. Again, we are very careful about that because stroke is generally a bad thing to have. So blood thinners are blood thinners, but what if patient has problems with bleeding already? Some patients have recurrent bleeding from digestive tract, from urinary tract, or even in the head. What if the patient is a high risk of bleeding? Let's say somebody has a lower level of clotting cells, or somebody who has a cancer, or somebody who has ulcers in the stomach. What if somebody is a high risk for falls or falling regularly? Because every time patient falls, it puts him or her at risk for trauma. And trauma can be related, can result into bleeding, including the bleeding in the head if head ends up being the part of the body that receives trauma. What if the patient is active in their employment or leisure? Let's say, what if somebody works as a roofer and they are up on the roof all the time. So if they fall down, they would be looking at a very high risk of trauma and bleeding. Or what if somebody is a horse rider, as a hobby or as a profession? Obviously, you can see there are some risks of trauma there as well. What if somebody have a hard time adhering to blood thinners? Because blood thinners, most of them, with the exception of warfarin, they're taken once or twice a day, and they have only limited time they spend in the body. So if patient cannot or unable to take the blood thinner on a scheduled basis, obviously they will not provide protection the patient needs to avoid the strokes. What if there is a need for the patient to be on medications which will interact with the blood thinners? Or what if he needs different blood thinners? Let's say some patients need blood thinners because they have stents in the heart. And there's different blood thinners available now for that reason, but unfortunately those blood thinners are not enough based on the current data to protect them from stroke because of atrial fibrillation. And putting them on 2 or 3 blood thinners obviously will put them at a very high bleeding risk. And what if somebody has very advanced kidney failure? Why does this matter? Because most of the new blood thinners, including rivaroxaban or Xarelto, apixaban, or Eliquis, they come out of from the body through the kidneys. And if kidneys don't work to the level for which these drugs were designed, extra amount of those medicines can sit in the body and increase the risk of toxicity, primarily increase the bleeding risk. So if patients with advanced kidney function could find themselves in a pretty tight spot. So what to do if those issues are present and in blood thinners long term do not sound like a good option? Well, as we talked earlier, the job of the blood thinners is to thin the blood and prevent the clots from occurring in this dead end on the left side of the heart, primarily, which is called this left atrial appendage. And when the researchers looked at the reasons why patients with atrial fibrillations have stroke, they actually found that 91% of the time, this is because of the clots occurring in this appendage. So if we cannot really thin the blood to prevent clots from happening, if patient cannot take blood thinners, what can we do with this pouch, knowing that this is a major troublemaker? But the question comes to mind, if this pouch is a troublemaker, why do we need this part of the top of the heart on the first place? Well, originally it has certain functions that helps the heart. For one of them is that's actually an organ that makes certain hormones. They're called neuropeptides, which in a way diuretics. So if the pressure increases on the top of the heart in this part of the heart in particular could make those chemicals to get rid of this extra fluid and decrease the pressure on the top of the heart. And also, if the pressure on the top of the heart is elevated, this appendage helps to decompress the top of the heart because this extra blood stretches it out and it decreases pressure that way. So in the design, it does have important functions to do. However, if it causes problems and we have to find the ways to protect patients from stroke, this part of the heart becomes a target for different approaches. And over the years, there have been different techniques in terms of what to do with this pouch to minimize risk of stroke. So the idea is to somehow close it up or exclude it from the circulation to make sure that the basis for the clot formation is no longer there. Currently, as heart rhythm doctors and sometimes the plumbers of the heart, interventional heart doctors, offer the procedure called left atrial appendage closure with Watchman device. Watchman device, how I call it, essentially a plug, which is made out of plastic and metal and it is used to plug up that dead end pouch we were talking about. The whole procedure is done through the groin, so you can see there are catheters, so big IVs going in the groin, similar to the ablation procedure, but obviously the manipulations are different. Initially, this plug is folded like an umbrella and is placed inside a thicker plastic tube. And the plastic tube, as you can see here, which is a blue tube right here, it goes up the vein and then into the heart. And once we find a good spot for us to put our plug, it will push it out. Again, it opens up like an umbrella. And if we like the spot and make sure there's no leaks around it, we just release it from the stick it is attached to. Everything else comes out, plug stays in. In about 6 months, this Watchman device will be covered by the normal tissue. But until then, essentially this plastic and metal are exposed to the blood, and they, in this structure, can become the basis for clots itself. That's why this procedure does come with the need for 6 months of blood thinners. If we talk about the procedure itself, actually, this is a picture right here of this umbrella, or this Watchman device or plug. In about 6 months, you can see it's entirely covered by the normal tissue, nothing really supposed to stick out and be exposed to the bloodstream. So far, there is no expiration date on that. Some patients wonder how often it needs to be replaced. So far, based on the modern practice, we are not expecting this device to be removed or replaced. Once it's in there, it's expected to stay as long as it can. When we do this procedure, most of the patients should expect to spend 1 night in the hospital for monitoring. And after that, for about months and a half, patient will need to be on one of the blood thinners we discussed, whether it's Eliquis, whether it's Xarelto, whether it's warfarin, whether it's Pradaxa, with aspirin. In about 1.5 months, we typically repeat ultrasound of the heart through patient's throat or esophagus to check on the position of this device, to make sure there's no leaks, make sure it's getting covered nicely by the normal tissue. And if we're happy with what we see, the blood thinners are downgraded to aspirin and the different blood thinner called Plavix or clopidogrel. This combination would stay on for another 4.5 months. And about 6 months from the time this device goes in the heart, patient can come off the blood thinners, and typically just baby aspirin once a day is all patients need, and he can expect to be protected from stroke. How good is this device compared to the blood thinners? Well, before being offered to patients in the United States, every device, medication, or intervention needs to go through trials to show their safety and efficacy and other parameters. So in the trials, this device was compared to Coumadin warfarin. And the study outcomes demonstrated that this device, at least as good as Coumadin warfarin in protecting patients from stroke. What if the blood thinners are not an option, period? Because commonly faced issues in my practice are with the patient who had very bad digestive tract bleeding, and digestive tract doctors or GI doctors would say patient is not a candidate to be on the blood thinners, even if it's a short term. Patients who have bleeding in their head, then the neurosurgeons would say, no, he cannot be on a blood thinner, even if it's for 1.5 months or even if it's for 6 months. So do we have any other options? Yes, we do. And the other options are surgical, occlusion of this left atrial appendage, and for which we would typically refer the patients to the cardiac surgery clinic to discuss the risks and benefit in the procedure itself. There are different techniques that surgeons use, and you can tie up or suture the pouch this from the inside or outside, you can cut it off and stitch up the remnant with the stitches. Some of the strategies unfortunately come with good possibility that the sutures would loosen up over time, and this appendage would get still connected to the bloodstream and continue to remain the culprit for strokes. One of the newer techniques that surgeons have to offer is a clip, and you can see it on this lower picture right here. So it's pretty tight, so we'll essentially clip it at the base of this pouch, and so far the results are pretty good. So it does a good job of excluding this pouch from the circulation and keeping it excluded over time. But it is it is an open heart surgery, although I think it's not that invasive. And unfortunately, if patient already had open heart surgery in the past, that would mean that they already have adhesions and scar tissue around the heart. So this another surgery may not be ideal for the patient, and those patients may not be offered this procedure. And we'll always do our best as physicians to find the best way to treat our patients and protect them from stroke. But however, some patients who are just in a tight spot and they're not a candidate for Watchman for whatever reason, and they're not a candidate for surgical closure either. So for some patients, we just have to accept the risk of stroke, knowing that based on the current practice, we just don't have a good options for them. It may change in the future, but as of right now, that's all we have. So in conclusion, management of atrial fibrillation is a complex process, and a risk of stroke and risk of bleeding must be assessed for every patient who is diagnosed with atrial fibrillation. And appropriate stroke prevention strategies should be discussed and chosen for for each individual patient, and the strategies can be adjusted in the future if patient circumstances change. Well, I think we got to the end of my presentation, and if there are any questions I can answer, I'll be happy to do that.